Generally in conferences, we have orthopedic surgeons, but here we have physicians, doctors, cardiologists, and discuss some parameters. I have about 40 minutes in hand, 30 minutes in hand to discuss some parameters, that is a 360-degree view to approach a patient. So I hope I am clear with this. So this is like, I'll be calling one orthopedic surgeon, but this round is open for all. And I have personally taken to moderate this session because this is the most important session which I presume. So first of all, I would like to invite Dr. Ashok sir, anesthetist sir, to be on the dais, please. He is a renowned anesthetist. Yes, sir, please, sir. I would like to invite Dr. Avinash sir, who is our in-house physician and a very eminent physician in Patna. And I would like to also invite Dr. John Moore sir, if he can come here on the dais, please. And I would like to invite also Dr. Ashok sir and Sushil sir, please. Yes. So the topic theme is 360 view to approach a patient. So keep thinking. My first question is, one second. So ultimately the slides would be presented by my our registrar, Dr. Kalyan, the few things which are the take-home message. But what is your take on cardiac evaluation of a patient? My questions are very straightforward. All eminent doctors are sitting here. I come for a TKR or a THR. So would you like to have a stress echo done for me, or would you go for a routine X-ray, echocardiography, or would you like to get a cardiac CT scan, or how do you go about it? A very open question. I mean, for fitness. And what is the protocol? Yes, sir. Please, sir. Colonel, sir. Please.
Sir, in our center, I practice at care hospitals, Ambali. Most of our, because it's a cardiac center, a lot of our patients who do come to us do tend to be high cardiac risks. So we routinely do subject them to a cardiac evaluation. Now the cardiologists by and large do tend to get a 2D echo. If they feel that the LVEF is significantly reduced, or if they anticipate some other problems, they tend to send them for a dynamic stress echo and then perhaps give us clearance. Now, I believe in today's day and age, perhaps it's much more of relevance in terms of medical legal aspects rather than more so than the actual risk purported. But nevertheless, this is what we are practicing.
Okay. So my next question goes to Dr. Ashok sir. He's an anesthetist and we have a cardiologist and physician here, Dr. Avinash. So what would you prefer, a stress echo or a normal echo or nothing? Young patient like me, I am coming, I want a THR done, nothing.
In young patient, we prefer 2D echo. If there is any findings, just like there is jerky septums, then we go for the stress echo.
And cutoff for LVEF, that is what we know as an orthopedic surgeon, we don't know much. Ejection fraction?
More than 50%.
More than 50%. What is your say, Dr. Ashok sir?
It's okay. 50% is okay.
Okay. Dr. John Moore sir, anything cardiac evaluation would you stress in America?
I defer completely to cardiology. A young person under 40 probably wouldn't get a workup at all if they're healthy. After 40, everybody gets an evaluation, and I would defer completely to the cardiologist on his determination about his ejection fraction.
And Dr. Sushil sir, what is your take? How would you like to do your spine patients or any case? Because we are doing planned surgeries. If the patient has some cardiac comorbidities, we lose faith actually.
So in planned cases, I prefer to do the stress echo.
Okay.
Basically, we doing the surgery, we're putting the stress over the patient. So how the heart work in the stress condition, it is more important. So I prefer to be the stress echo.
And Dr. Ashok sir?
Same.
Same. Dr. Ashok sir, stress echo. So Dr. Kalyan is here. Yeah, Dr. Kalyan, yeah, please come. So we did a lot of study on this. Please come, you have to present it. I am just a moderator. So we did a lot of study on this. So what I do routine echo for all the patients above 40 years. That is a part of game for everybody, ECG for all patients. But when we talk of stress echo, anybody above 50, I go for a planned 2D stress echo. And of course, I get a cardiac opinion. And out of 10 patients, 1 to 2 patients land up with having some problems, ischemic event in stress echo, and they go for angiography or whatever the cardiologist believes to do so. But the take, what I believe is that we should fully evaluate the patients, and I routinely do stress echo at our institute for all planned patients at least above 40 and routine echo. But now Dr. Kalyan will present the latest literature, what is the say of meta-analysis and everything. So we have some burning questions here, and I have a couple of papers which will just take you around and show what has to be done according to literature. And if any input, we'll all can add anything. Please, Kalyan. All yours.
Thank you, sir. Thank you. Hello, everyone. Good afternoon. Warm welcome to all the delegates, faculties, and the panel members. I'm Dr. Kalyan, FNB arthroplasty resident from Anup Institute of Orthopedics. So I'm here to speak about pre-operative evaluation in cardiac and diabetic patients who are planned for total joint arthroplasty. Somehow, 1 second. Yeah. So pre-operative clinical predictors for cardiology referral prior to total joint arthroplasty, we really don't have, there's no tool that is specific for total hip and knee arthroplasty. To reduce the risk of post-operative cardiac complications, as a surgeon, we need clear guidance on which patients are likely to benefit from pre-operative cardiac optimization. So this is particularly important for asymptomatic patients where the need is harder to determine. Cardiac complications represent a major cause of morbidity and mortality after total joint arthroplasty and is associated with increased hospital mortality and length of the stay. Although the rates of major cardiac events are reported as low as 0.2 to 0.8%, but this risk is expected to be higher in near future. So, however, we do pre-operative cardiology assessment including a baseline echocardiogram and electrocardiogram to be done in all subjects undergoing joint replacement. Here now, the risk is stratified between asymptomatic and cardiac symptomatic patients. The outcome variables for this analysis were, if anything is found in echo, routine echo or ECG, we do additional cardiac investigations which is ordered by a cardiologist, which includes angiogram, stress echo, CT coronary angiography, and myocardial perfusion scan. Any abnormalities detected, they are further evaluated by a cardiologist. So now, the total joint arthroplastic cardiac risk index is what we have the most economical and which predicts the post-operative cardiac complications. However, the revised cardiac risk index is not that significant. This is an article from cardiology, which tells us about the stress echocardiography, role of stress echocardiography in ischemic and non-ischemic cardiac diseases. So, vasodilator stress echocardiography has the most specific of all the tests, and coronary CT angiography is the most sensitive of all the tests. This is a table which shows us where exercise stress echocardiography can be done and pharmacological like dopamine stress echocardiography can be done with all the cardiac conditions. But however, according to JAMA Cardiology article, the frequency and outcomes of preoperative stress testing in total joint arthroplasty from 2000 to 2017, it has come down. The frequency has come down over time. Regarding the body mass index, according to WHO, we define underweight, normal weight, and overweight, and obese too. So, very obese patients had an increased risk of major adverse cardiac events and mortality, both in short term and long term. Now, coming to diabetic evaluation.
Take over from here.
Yes, sir.
So this was one topic. So what I would like to highlight here that we should be safe because we are all orthopedic surgeons, and problems which we face are medical problems. So we should have a clearance, either a simple 2D echo. If we have some issues with the echo, then go for a stress echo and get it evaluated by a proper physician, a proper anesthetist, and a proper cardiologist. And if anything happens, then in Hindi I can say Rab Rakha. Bhagwan ke upar ab kya hota hai. But we should be safe, especially in this medical legal era. Now coming to my next question, very pertinent question. What is the cutoff for HbA1c? I was diagnosed to be having diabetes, and I was at Bangalore, and my HbA1c was 16.2. I've never seen HbA1c 16.2. Yesterday I refused a patient with HbA1c of 10. I refused, clearly right. So what is the HbA1c, Dr. Vinash?
6.5 to 7.
6.5.
Ideally 6.5 to 7.
Okay.
5 to
And your John Moore, sir, anything?
The Hip and Knee Society did this study, and they came up with a flat line that showed that up until 7.7, there was no increased risk of infection, and after 7.7, that's the cutoff that we use pretty much routinely.
Sushil, sir, how would you plan your case for, I mean, we are doing planned cases, so we need to have a baseline
So we're doing the planned cases, the HbA1c is around 6.
around 6. Ashok, sir? Up to 7. Sir, any faculties, any quick clues from any? Dr. Saraf, sir, what would you like to do? 6, 7, 5? Okay. Dr. Surene, sir, anything from your side? 6.5, 7? Any input from the faculties? Yes, sir. Okay, sir. So now, Dr.
6 or around that, we see lot of hypoglycemic events
Still.
in the patients. So it should be 7.5 should be the mark what I feel is
Okay.
correct.
So I'll just pass on
Sir,
the mic to Dr. Kalyan, who has, we had reviewed, yes, yes, sorry.
Dr. Shashidhar from Bangalore. My friend who is an endocrinologist, he says that it is not the HbA1c but perioperative sugar control which is required for infection, as a part of infection if you are looking at. But if you are looking at other physiological aspects which can happen because of hyperglycemia, constant hyperglycemia, then of course HbA1c. But if as an orthopedic surgeon, if you are looking at as an part of possible infection post-operative, it is the perioperative sugar control and not HbA1c.
Recent data suggests that HbA1c, higher HbA1c is related to the higher wound complications.
I have done actually in a HbA1c more than 10.5, but fortunately there was no issue because
man.
perioperative sugar control was fantastically maintained.
Yes, sir. Anything from John Moore, sir?
Fructosamine is another test that can be done in a 3-week period following. So it's the glycosylated portion of albumin instead of hemoglobin.
Okay.
Antonio Chen has told us that after surgery, even in non-diabetics, if the blood sugar stays above 200 in a postprandial state, 7 o'clock at night is a typical, then that also inhibits the white cell's ability to fight off infection. So not only the hemoglobin A1C with the fructosamine and then a constant carbohydrate diet to maintain the blood sugar at or below 200 at all times, especially in the evening meal.
Okay. So I'll pass on the mic to Dr. Kalyan for what have we got in the recent literature studies. Yes, please.
Thank you, sir. Now, coming to diabetic evaluation in joint arthroplasty. So, definition of diabetes, diagnosed diabetes if they have previous diagnosis of diabetes based on medical records and self-reported questionnaire, and undiagnosed diabetes if their HbA1c level was 6.5 or greater, and pre-diabetics where HbA1c level was 5.7 to 6.4. All patients should be screened for diabetes prior to total joint arthroplasty. Since diabetes is a highly prevalent in patients with osteoarthritis prior to joint arthroplasty, and it confers a higher risk of adverse post-operative outcomes. However, the rate of diabetes in this population and optimal screening strategies remain unknown. So, we strongly recommend a universal glycemic screening of all elective arthroplasty patients. This article shows that diabetes is a single independent predictor for severe osteoarthritis. Type 2 diabetes predicts the development of severe osteoarthritis independent of age and BMI. Our findings strengthen the concept of a strong metabolic component in the pathogenesis of osteoarthritis. Now, determining the threshold for HbA1c as a predictor for adverse outcomes. Studies show that more than 30% of patients undergoing total joint arthroplasty have undiagnosed dysglycemia. The American Diabetic Association states that HbA1c greater than 7 may be indicative of poor glucose control. However, high HbA1c levels are associated with increased risk of periprosthetic joint infection. A threshold of 7.7 should be perhaps be the goal in preoperative patient optimization. Now, fructosamine is a better glycemic marker when compared to HbA1c in predicting adverse outcomes following total knee joint arthroplasty. The cutoff for fructosamine levels are 293 micromoles per liter was identified, and fructosamine is a valid and excellent predictor of complications following total joint arthroplasty. It reflects the glycemic control over 2 to 3 weeks period time. And fructosamine is better predictive of adverse outcomes than HbA1c. HbA1c is used to diagnose, and fructosamine is used to predict the perioperative glucose control over 2 to 3 weeks of time. Fructosamine responds quicker to treatment, thus it makes us possible to avoid postponement of elective knee arthroplasty. Is hemoglobin, HbA1c and perioperative hyperglycemia predictive of periprosthetic joint infections following total joint arthroplasty? Yes. The present meta-analysis shows that high HbA1c and perioperative hyperglycemia are associated with higher risk of PJI following total joint arthroplasty. So screening of HbA1c and perioperative blood glucose is therefore an effective method to predict the deep infection. Now, optimal time period for blood glucose level evaluation after total knee arthroplasty in patients without diabetes. It is post-operative day 2. That is the time where we can get the correct value of glucose and try to optimize it. Thank you team IIR.
So 7.7 is the cutoff. Fructosamine test is done with the Lal Path Labs in Patna. Rest for other states I don't know, but this is the basic scenario. And next session I would like to call Dr. Akash. So he will be talking on. May I have his slide, please? Akash.